diagnosis of the posterior capsular tear. Inevitably, as cataract surgeons, all of us who are bound to experience posterior capsular tear, and let me share you some of the tips on how to diagnose early. It can happen during any stage of cataract surgery. So, when to suspect a PC tear with an overlying nucleus? It is almost a half the battle won when you diagnose the PC tear at very early stage, because you're going to prevent the nucleus drop, rupture of the anterior-hyaloid and vitreous disturbance and prolapse. Then it also prevents PC tear enlargement, collateral damage to the other ocular structures like iris, cornea and retina. Finally, when we have effectively managed PC tear, then we have a high chance of implanting the IOL. So in this case, just viscoelastic is filled in the anterior chamber. You can see the PC dehiscence. A small replay here. And in this case, irrigating BSS, there is this pupillary snap sign. Both the cases underwent vitrectomy and they were managed with IOL implantation. Here, the radial rexis with a wraparound tear where the PC has been torn, and beginner's dilemma of a small rexis and difficult nuclear rotation. When it comes to nucleus management, it can also happen. This is the beginning stages of epinucleus removal, and you can see the nucleus tilting and trying to get inside. Fragment is at a deeper plane and disappears underneath the rexis margin. Here followability is poor. Why? Because the vitreous is clogging the phaco-tip. So the nucleus does not move towards the phaco-tip at all. Here there is sudden enlargement of the red glow, bright unusual red reflex, a sudden feeling of giving away or pop, sudden deepening of the anterior chamber. To summarize, the important signs are nucleus tilting, poor followability, enhanced red glow, sudden deepening of the anterior chamber. Coming to the next critical important step of discussing PC tear with nucleus in situ is, why does the nucleus drop? When there is a large PC tear with an overlying big nucleus with a positive hydrostatic pressure which is seen in phacoemulsification, there is no way or no place for the nucleus to disappear. It goes into the vitreous. This all depends on the physical state of the vitreous as well. Sometimes we notice that when the vitreous is in a gel form, as in younger patients, it stays in place, but in elderly and very old patients, it has a tendency to sink. Sometimes vitreous also has a role of a third hand helping the surgeon. So surgical objectives are something very similar to how a pilot lands a plane with some snag. The 5 things to do are: diagnose the posterior capsular tear at the earliest, avoid panic and don't remove the handpiece, inflame the anterior chamber with a viscoelastic before removing the handpiece, reassess the situation, and based on the skill and experience, you can proceed towards phacoemulsification, or you can convert to small incision cataract surgery. Here, all the steps have gone smoothly. Hydrodissection, nucleus rotation, everything has happened very well. As we can see, the rotation of the nucleus is easy. Each of the fragments are being, the sculpt is being done. The stop and chop technique is being carried out here. So the lateral separation is done here. Each of the heminucleus is further fragmented. As is seen, the nucleus is of grade 2 density. When the penultimate fragment is being chewed, we can see suddenly there is a PC tear because the power is delivered is excess, or maybe the chopper was at a deeper plane than usual. So here, before removing the handpiece, the mistake was the handpiece was removed before the OVD was injected. That is not to be done. Each of the fragments are brought to an anterior level. Almost in the anterior chamber, the phaco is being carried out. Always dispersive OVD has to be used tamponade the vitreous so that the vitreous does not keep on percolating into the anterior chamber. Limited anterior vitrectomy is being carried out here. Once the nucleus fragments are removed, the cortex is removed using the same or vitrectomy cutter, or you can use the bimanual irrigation aspiration as is being done here. So as we can see, there is a V-shaped tear running between 9 o'clock to around 7 o'clock hour. Be sure that the vitreous is not there in the anterior chamber or within the bag whenever you are implanting the IOL. This is usually done by confirming using intraoperative triamcinolone acetonide diluted 1:4. Now the chosen IOL is implanted in the bag. So the last step is to remove the residual vitreous and also the viscoelastic which is used in excess here to protect the endothelium and as with the bag. Coming to the second case, this is an intumescent mature cataract. As we can see, the nucleus is around grade 4 density here. Direct chop has been done, and just when the first fragment has been removed, you see that there is a glaring red glow seen, and obviously there is a large PC tear just at the beginning of the nucleus management. The other eye examination had revealed that this is a patient who had posterior polar cataract. So intraoperatively, I was sure that the anterior highlight was not breached, so I went ahead again in this case with phacoemulsification. Each of the nucleus is brought to the anterior chamber and managed. This is critical because you can't go at a deeper plane when there is a total lack of posterior capsule. You have to use copious viscoelastic to protect the endothelium and tamponade the vitreous down. So until this stage, there is no disturbance of the vitreous, and the vitreous itself is acting like a third hand trying to hold the nucleus up. This is an young patient. The vitreous is obviously in a gel form and there is no disturbance of the vitreous. So the cutter is being used to remove the cortex from within the bag. Invariably, these cases are going to consume a lot of surgical time. You have to be mentally prepared for these cases where the time consumed for each case is going to be longer. So each of the steps have to be taken meticulously and managed carefully. The cortex removal is being done. So I noticed at the very last stage of cortex removal that there is probably disturbance of the vitreous. I used triamcinolone acetonide again here with the diluted 1:4 concentration. I identify that the vitreous is disturbed. It is a tad bit difficult to identify vitreous disturbance when you have used in excess viscoelastics, but with little bit of clinical surgical experience it is easier to identify, and as such triamcinolone acetonide is a great tool to identify vitreous disturbance. That was the final picture after the IOL implantation. Coming to the last case, this is a deep AC. Here we can see that a gentle hydrodissection is being carried out. Just when the first step of phaco is being begun, you see that the nucleus starts to tilt. So in this situation, when the entire nucleus is within the bag and it is trying to go down, you have no other option but to convert it to small incision cataract surgery. So either you have a choice of shifting to the superior area, or you can convert your temporal phaco incision as a small incision and do removal of the nucleus through the scleral tunnel wound. So brought out, limited anterior vitrectomy is carried out, and let me skip these few steps and see. Generally, the vitreous has a tendency, it shows a tendency to prolapse towards the main node, and that is where you need to be meticulous about your anterior vitrectomy. A multi-piece IOL is being implanted in the sulcus with the optic capture. So optic capture generally ensures long-term stability of the IOL. In the post-op, the patient was finally doing well. Ovalization of the rhexis margin indicates optic capture, and this is the fastest. Setup, we need to have setup of all vitrectomy cutter, triamcinolone, acetonide. You have to have a thorough drill of all the steps that has to be undertaken for vitrectomy. Never go fishing for the nucleus because it can cause giant retinal tears and retinal detachment. And finally, being mentally prepared for this stressful situation is very necessary to handle with calm and composure.